Good afternoon, everyone. I mentioned I'm Gary Clough, and I'm a research assistant at the University of Manchester, and I am delighted to be here today. Thank you to Richard for inviting me to talk. I'm going to speak to you today about my project, which I'm very passionate about. It's a very passionate project called Urban Health Centres Europe 2.0, or put as a mouthful, UHCE is what we refer to it from now on. And I'm the project lead for this project. Just to tell you a little bit about me and my department, this is us, we're a Manchester Urban Collaboration on Health, but because we like acronyms, we prefer to call much. Much down the back there. And this is just our staff structure. We've got our manager, Dr. Aparna Verma. I'm sure some of you might know who she is. She's done quite a few conferences recently. And then there's the rest of us who will be working on the project UHCE. And we're based within the Institute of Population Health, and we do population health / public health research. I've done that for many, many years. These are a few of our collaborations. There's one project in particular which is kind of our flagship project called Europe Initiative, and we've got the largest set of urban health indicators in the world. So we're very excited about that. We've got a lot of collaborations, and as of 2 weeks ago, we're a World Health Organization collaborating centre, which is a very grand title. It means that we can work very closely with WHO and use their data sets to further promote public health, and it's fantastic. I'm very proud to be part of that organisation. And these are just some of our partners worldwide, so you can see we've got a really large network. So back to UHCE. It is a project which started in 2014, and the idea was to focus on health and social care and improving it based on 4 outcomes: frailty, fall prevention, polypharmacy, which is the management of multiple medications, and social isolation within people who are classed as over 75 and within Tameside, Watford and South Manchester. So we intend to boost the health and social care available. We got funding from the European Commission, the University of Rotterdam, who's one of our partners, who's actually leading the project. They received this money and we got allocated 73,000 from that amount, and that's going to be based in Manchester and delivering services over the next 3 years. Just to show you the partners that are involved in the project, obviously there's one in the top left in Manchester, we've got the University of Rotterdam, we've got Valencia in Spain, and we've got Rijeka in Croatia, and I was very, very happy to actually go there for a conference and speak to them about it. We've got to go to lovely Croatia, it is as beautiful as everyone says it is, and we've got Polini in Greece as well. In Manchester we focused on 2 sites, which is South Manchester and Tameside, and that's exclusively because we've got so many good connections with people like Richard, and we managed to get such a great network that we're able to do some fantastic research within these areas, so we chose to do these areas once again. So phase 1 of the project started in early 2014. We got ethical approval in September and finished phase 1 in March just gone. And we were asked to conduct focus groups with 4 sets of population, including senior citizens, health and social care professionals, informal carers and policy makers, so we can get a wide term of what they think health and social care wise needs to be addressed and what's good practice. So within the senior citizens group, we had some eligibility criteria. You had to be over 70 years of age, not suffering from dementia, not living in a nursing home, and be living in the regions of South Manchester, Tameside and Gloucester, because that's the areas we want to target the intervention. And because we don't have anybody who speaks multiple languages, there's a very ignorant department on learning the language. We couldn't have anyone who needed a translator. And the reason why we used the top 3 there as their eligibility criteria is because through our ethics, we need to make sure we're able to target people who are too vulnerable to take part in research. So it's we have to make sure that it's suitable for the people we're actually researching. So in the focus groups, we had help from some of our networks, some people I've already worked with, and we organised these focus groups within community centres and attached to hospitals, so these areas that patients would know, and like trusted areas somewhere that they've been before. And we try to make it nice and easy for us, so we make sure there's some catering involved, and we've kept it to 90 minutes because we don't spend too too much time and make it more suitable for them. And I've tried to display some of the results from this phase of the project, and the best way to think of is actually some quotations from the senior citizens themselves. As you can see here, some of the points they make are far-ranging, covered an amount of different thoughts across different disciplines of what they think is needed to change health and social care. As you see here, it mentions a lot on polypharmacy, so the amount of medication we got, there's a lot of positive and negative comments coming from that. In these cases, they found that in pharmacists, and on this one occasion, this gentleman went to the pharmacy, and the pharmacist was kind enough to ask him to come behind the bar and discuss the way in which he received his medication. And he was very happy with that, and he's got a good relationship with his pharmacist, and he's able to review which tablets he should be taking and ones that maybe are not necessarily needed from then on, so he was able to review it. However, there's these examples here where they were still taking tablets from 20 years ago, and that's due to, according to this gentleman, it's because he's not been reviewing his drug intake, and it's maybe one of the things that we need to highlight and maybe be addressed as part of our project. I think somebody will just come up to the slide a little bit, but some mentioned about going to pharmacists and the working hours, but this is quite a common theme that we found from the focus groups, that they turn up at the pharmacist to get the blood pressure checks, and the hours that the pharmacists are working are sometimes unsuitable, especially around lunch hours. This was quite an interesting case here where this gentleman went into hospital, and it was a prime example of it being managed by two separate doctors. One was looking more towards his dementia, Alzheimer's, and one was looking more towards his liver function, and one of the tablets was really influencing the other, and so they cancelled out, and the reason he found out this was the case it was causing actual harm is because this doctor in the hospital picked it up, and it was only by chance that this happened, so his left hand and right hand not speaking in this circumstance, and it was highlighted by this focus group. With regard to social isolation, it was quite interesting to see how technology comes into play. Once again, mixed reviews. There's the big section of the focus group population who loved the idea of Skype and all its facilities. They were able to speak to more of the family than friends. However, there's another argument saying that as technology goes up, face-to-face contact goes dramatically down, and comfort and speaking to your family and friends personally and being able to hug them is somehow inhibited by the technology. So very much flip side opinions, but we got quite a lot of data from that. Ways in which socialisation is trying to be addressed really by this population. There's quite a few different ways, and the ones picked out here is that they use pets to make themselves feel much more part of society and associate with neighbours, so if they share like pets, etc. And there was quite a nice example of this lady who said that she had a cat for 17 years, but was afraid to get another cat because of how the lifespan of the cat is, that she thought she might die before the cat, and she wanted to leave on its own, so she bought a goldfish, and that lasted 12 years. So goes on a little bit further to sometimes we try to address social isolation through activities which kind of blends very well into the next bit, which is fall prevention and frailty. They try to address it by going out to dance classes which don't require too much rigorous activity, or doing gardening or managing an allotment, and these are just ways in which they manage to adapt so that they can not be isolated in home. There's this example here which is quite interesting as well, where this person was isolated in the house for 6 and a bit years, and just one bit of technology or one bit of help from social care, and she was zipping around on a motor scooter back in society, and that's just one small little change. And we hope to do 10 million times more changes with this project, so it's a very good initiative. With regards to frailty and falls prevention, I've already mentioned that mobility scooters are a good asset. Once again, this allows people to overcome the fear of going outdoors and thinking they might fall over. If they've got a mobility scooter, they're much more likely to go outside, and frailty and falls prevention is not something much on the mind, so people would walk over the road and tripping on the curb. As I mentioned there, the dance classes and little community events really come into play. And I think this is one of the most surprising elements I found from this research is that the community aspect of when I spoke to people in South Manchester and Thames Iron Loss, that the community, that everyone's looking after each other and making sure that people aren't isolated and helping each other if the falls, people fall, they need help. It's such like an endearing thing about it, really realistic to me, something you won't get from just reading data, actually speaking to these people in person, something fantastic that needs to be highlighted in this project. And there was quite a flip side on if they considered their social care to be good. And when it comes to patients, they all love the social care. And I believe when we go into informal care in a second, it's partly the opposite of that. But for this case, patients found that the social care when it came in was fantastic. They brought appliances which made dramatic differences in their lives. And they were well received, they got to speak to and made them less lonely. So these are some of the things that came out from speaking to in the focus groups. Technology, health and social care communication, drug management, sporting services, family connecting community, and the idea of golden years, where they mentioned in the focus group that they were, when you retired, managing the pension, that they were expecting to go on holiday, and there was quite a lot and just enjoy life and be able to have time to look after themselves and enjoy life. And unfortunately, many things that get in the way of that, and one of the main things that came up was holiday insurance. One of the people who go to bed because she was 85, unfortunately. So there's a lot of restrictions out there, but hopefully with this project we could highlight these and make some difference as we speak to policymakers. When we spoke to health and social care staff, these consist of many different disciplines: practice managers, GPs, nursing staff, pharmacists, hospital health workers. So we've got quite a range of responses, and quite surprisingly, they have exactly the same sort of thoughts on health and social care as patients do. Some of them weren't happy with how much care was exhibited towards patients because of the system itself, that they could only, if they came into hospital and got discharged, they could only have 10 days worth of checking up on the patient, make sure they're okay, and then they couldn't afford to do any more. So these sort of thoughts that the patients that brought to the veterans was mirrored in health and social care. One of the most interesting points I saw was that pharmacists have now become more of a pivotal organisation, which is quite surprising because I didn't really think about it until this moment. But the pharmacists are now more a caring facility instead of just providing drugs. They're actually getting, in some places, the actual drivers who deliver the drugs to make sure that the people they're delivering it to are well and they're showing any symptoms which they're not reporting to their GP and reporting back to them. So more of a supporting service which I think needs to be nurtured and brought across Greater Manchester, because what a fantastic example that is, that they're looking at the patients they drive to.
In my experience of working recently in a pharmacy,
the
pharmacist, when a patient comes with a drug and they're looking at the medication and the drug they've been prescribed that day, if it's a new drug, then they do a follow-up on them. They speak to them and say, we'll either phone you up or, we'll do a follow-up. So, and they do regular reviews. I don't know if that's in every pharmacy, but, that's quite good now.
Absolutely, it's looking like good practice now, which is and as this is just a European study, these sort of things might not be mirrored in some of the other countries, some of the other cities that are taking part in the project, and it'd be a great example to say, here's a fantastic example here, we think you should definitely promote it in your country and try to get health and social care improved across Europe. These are some of more quotes that come through. This is from the informal carers, and I actually directly led these focus groups, so I spoke to them in person. The informal carers, I've got overall some of the quotes that come out here, is that they're quite unhappy with the support they're getting for being informal carers, because in some cases, looking after someone is such not to say a chore, sorry, it's so hard to actually do that they make themselves ill, and the support there it's not currently in there to support the informal carers. Yes, they do get some allowances, but it's not enough usually to cover them, especially if they want to go on holiday. There's no one to really replace them unless you go private. And you can see they're actually getting really upset because there isn't a support for informal carers. And in some cases, the informal carers are the next door neighbour, and they're the same age, she's just a little bit more agile on the feet. And it's quite worrying that this is the current way in which this is played. And one of the things that came out as well was this data protection, because if you're the neighbour who's looking after somebody who's 85, and that person didn't have any family, and you were their main carer, if they ever went into hospital and then the staff there wouldn't tell you exactly anything that goes wrong because you're not their direct relative. So you might be number one carer, but you won't get any information. As one person puts it in this focus group, this data protection is more of an inhibitor than a helper, unfortunately, and it's something that definitely needs to be addressed. Once again, policymakers, when we spoke to policymakers, the same things I've mentioned in the previous slides seem to have come through, and the main things are that finances are just not there to support people in the long term. There's a little bit of side, there's little programs going out there trying to help, but they're not all tied up together, they're not working in tandem with other organisations, so the effects that they're having is very minimal. And in some cases, as this gentleman mentioned, even he doesn't know what's going on, so how can anyone else expect to know what's going on as well? So phase 2 of the project, and this has just recently started. It's a huge data gathering exercise, and the idea is we're going to help GP practices with their patients. That's the entire idea. We're working with GPs to make their patients who are in this bracket of over 75 and making sure that their lives are dramatically improved. So we're going to get a wealth of data, and we're going to work in tandem with GPs and healthcare staff to improve patients' lives. So we've been tasked with recruiting 250 eligible participants. That's eligible participants for the previous slide, so we've got to be over 75, not cognitively impaired, not in nursing homes. In South Manchester, another 250 in the same type of Glossop. And the idea is that our research team are going to do home visits to speak to the participants and get them to fill in a questionnaire, which on the next slide. Questionnaire, a home hazard assessment, we're going to measure their hand grip strength and measure the upper arm circumference. And with all 500 data sets we're going to gather here, we'll be able to consult with GPs or their allocated healthcare professional to discuss what this project has highlighted as problems or things that need to be addressed, and making sure that a care pathway is developed from that using local amenities and local programmes in the area to make sure that frailties and fall prevention and social isolation and polypharmacy are all considered, and all this data will be able to help support this. We've got a few challenges we're expecting. GP practice participation, unfortunately, is down to good faith, really, or community champions. If they've got a particular interest in helping the elderly, that they're a champion of the elderly, they're more likely to take part. We have tried to come up with incentives. We have applied for and received funding to provide money back to the GP practice and reimbursement for the time. But we do understand that GPs are very, very busy, and sometimes prioritisation of research projects are lower down on the list. But if the idea is to try and promote it and to say that it's not just a research project, it's a way in which we're going to help GPs help their patients more, and hope to work in tandem with that. And because it's quite invasive, we're going to visit patients in their home. Participants might not want us to, so there's going to be a challenge having to overcome the thinking through the GPs who they trust, or people they trust will be able to do that. So the future of UHCE, we're going to have a huge wealth of data across the entire of Europe, and by 2017 we hope to dramatically improve the health and social care for the participants in the project, and we really believe that is going to happen because the response we've received so far from GPs has been so positive, and we hope that the participants will be just as positive in making sure that they tell us what they think needs to be addressed, and we can do that. So the idea of it is that after this pilot project goes on. You're in Master, that's all over the cities as well in Europe. And it's just a very quick slide on a conference that's coming very soon. It's the International Festival of Public Health UK. It's into its 4th year, and we're talking about public health issues at the University of Manchester with these fantastic presenters. And if you'd like to take part, just catch me at this presentation, because we can guarantee a free ticket for people here and also free lunch as well. So thank you. Any questions?
Thank you, Gary. Really interesting. Yeah. I couldn't, because I can't see. Can I have the slide back on? We can just check that. When is it?
2nd of July. The leader of the Green Party coming, Natalie Bennett, is one of our main plenary speakers, as well as a range of fantastic professors and doctors from public health, global health, and this project I just mentioned there will be once again talked about again in a few more presentations.
Yeah, that's great. And what do we get? Free?
Free ticket, yeah, free go, free activities, free bag,
Not
delegate bag, free lunch, hot lunch.
Sorry?
Yeah.
Free pen? Oh, gosh.
Where's it at? Where's it based?
You know the Stopford Building, University of Manchester. It's very close to the huge church right on Oxford Road.
It's on Oxford Road.
Yeah.
That's great, thank you. We've got time for a question, if anybody has one. Okay.
Just making a point which I know John's going to address. About some years ago, I was on the National Care Record Development Board for about a year. We were trying to develop care records. One of the patients on that group had HIV. Very eloquent, and he said he had exactly the same experience as some of the people you were talking to had, but they couldn't find out what's wrong with it. And people can't find out what's happened, what's wrong with their relatives or their neighbours, and not allowed to find it out. And I think it's wrong. I think it's really wrong. So they are, you've been hearing about it. So I think it's a common thing.
Yeah, definitely. Thank you very much.